I have created this video just to motivate and inspire my colleagues so that they start ROP screening if they are not doing so. And we'll talk about why this is needed and how it can help you in your practice and how to do it. This is actually a part of a presentation in the Kanpur Ophthalmic Society held recently, and the same presentation is being re-delivered by me for my YouTube channel. Now, looking at the diseases and the profile of diseases which are suitable for screening purposes, and we'll find that the screening is done for conditions in which the sufferer at that particular point where the disease could be detected is not aware of the condition. Secondly, that the late presentation or advanced stage has serious consequences in terms of mortality and morbidity. And finally, that the vulnerable population can be easily defined in strict criteria. And ROP fits into these. The affected population, that is neonates, they cannot communicate about their suffering, and the outcomes are extremely poor if not detected and treated timely. And finally, that the vulnerable population is very well defined. We have distinct criteria which can define those children who are bound to have risk for having ROP. Coming to the point why to do ROP screening, advantage to the hospital or the doctor. It will add some expansion in your already provided services, and this will help in generating more revenue. It will also improve your footfall, which will indirectly affect the number of patients attending the hospital and also the revenue. It will enhance the existing professional skill set. And finally, the best part is that you don't need any additional resources for starting this service, in contrast to any other service like refractive surgery if you want to add something like that. So this is very good for the practicing doctor and the hospital if ROP screening is initiated in their premises. Looking at what service we are providing and how important this is, we have very few number of ophthalmologists who are doing comprehensive ROP management, and this will exclude those who are doing just screening. However, we can see that this is a very minuscule number of ophthalmologists as seen in 2019, that only 150 to 200 ophthalmologists over whole of the India were estimated to be doing comprehensive management of ROP. And if you start screening, maybe that in coming future you may also shift to that, and that will add to the requirement of the service for this disease. And it is also known that with the coming times we'll have increase in number of neonates who are surviving with less than optimum birth weight, and that will also add to the burden of the disease. And late presentation and late complication of ROP is irreversible blindness. So this is actually a service for the community if you start doing it. Now, why people are reluctant to do ROP screening? The myth number one is that there are hefty fines if one falters in diagnosing and treating ROP. This is partly true. However, the reason that this is a myth is because this hefty fine and these medical legal issues being dragged to the court are usually related to the pediatrician and the neonatologist who has forgotten to advise timely screening for ROP. And we'll just see that this publication, the QR code is displayed here, will lead you to the article by Dr. Anand Venekar, which is about compilation of cases done for ROP failures. And if you look at this list, we'll find that we have this one particular case which was against pediatrician and ophthalmologist both. And this there are a few lessons for ophthalmologists to learn here, that the ophthalmologists are also liable if they start taking the responsibility for screening a baby for ROP. And the reason why this was punishment or the penalty was imposed on ophthalmologist is that the the findings were not properly documented. So we can learn out of it that how to go about it, and we should be following the published guidelines rather than expert opinion, as the court will follow the expert opinion and published guidelines only. So in nutshell, by this time you would have understood that this is a disease which needs some kind of active participation of the ophthalmologist community, but at the same time there are some pitfalls. So this corresponds to one of my favorite songs by Sahil Lidwanvi. जहर भी देते हैं और कहते हैं कि पीना होगा, जब मैं पीता हूँ तो कहते हैं कि मरना होगा, जब मैं मरता हूँ तो कहते हैं कि जीना होगा. So all contradictory statements being issued by me up till now. But this is something which we all know that this is a professional hazard. When we are involved in healthcare delivery, we have to act responsibly, and we are all vulnerable to have medical legal issues in all diseases which we manage. So we have to take care and take this as a professional hazard. So this should not be a deterrent for us for starting ROP screening. Now, when we have seen that what are the pitfalls, we can always come up and save ourselves from falling into these pitfalls. And I'll just guide you through how to do ROP screening with minimum of resources and all the security provided from the medical legal issues. Now, ROP screening can be easily done in OPD. Choose a secluded room. This would be a best suited because you don't want anyone to be recording your protocols, and also not recording whatever examination we are doing. It is not a public affair, and the examination couch is required along with following indirect ophthalmoscope with a preferably a 28 diopter condensing lens. This will provide you a wider field of view, and eye speculum, the photograph of which is attached, and this is known as Alfonso speculum. It is easier to remove and insert, and dilatation of the pupil using diluted tropicamide phenylephrine eye drops. And along with that, we may need a scleral depressor at times, which can also be done using a swab stick. Now, how to prepare a child for ROP evaluation? Feed the neonate or the child half an hour before the evaluation process, and pacifiers using glucose swab and pacifier can be used. The child will be more comfortable. Diluted eye drops of adult dose of tropicamide and phenylephrine are to be used, and only two instillation 10 minutes apart can be given, not more than that. And take care should be taken that any drug which has been spilled over the skin should be wiped away. And those neonates who do not dilate in spite of two instillation of tropicamide at a gap of 10 minutes may not dilate because of the ROP being advanced and affecting the pupil mobility. Now, this is an important part, as I was telling, that inadequate documentation can lead to litigations and penalty by the court. So we have to have robust documentation, and this will help you in having this robust documentation. And I'll just share this QR code, which will lead you to a URL which will have updated PDF of the case sheet which we are using at KGMU, and this will be properly updated, and this has been updated, and this is the latest version, and it will always be available for all of us to use. This is a two-page document which can be printed on the one side and the other side of a A4 size sheet, and can be used for documenting the ROP findings. And we'll just go through each section one by one. So this, the upper part has the patient identity and a few details regarding the disease and the child. Then we have the risk factors which are enumerated here, and they just need to be ticked so that none has to remember these risk factors, and all are included while assessing the child. And then we have this graphical representation of the ROP, which the drawing can be done. And I will not go into the classification and the staging of ROP. That is a separate lecture which is beyond the scope of this particular topic. And then we have few formalities like consent, which is documented in the same sheet, so that whenever the patient presents to us with documents, there's already a consent available and you don't have to keep a data or save that data for yourself. And there's final statement in terms of the plan, or then the right and the left eye is the part which is associated to the diagram. So plan has to be ticked accordingly so that there's no ambiguity left about the plan and treatment and advice. And then this comes the other side of the sheet, which has the examination findings. And first of all, we have the anterior segment examination findings and the media. So there may be situation where the unit which is being examined may have some other disease, congenital disease, which can be uh, marked here if it is anterior segment disease. And then we have chart where you can simply tick about the classification of the disease and the staging, so that it has zone 1, zone 2, zone 3 for both the eyes, and the comment about vascularization and stage of ROP. Down we have plus disease and regressed ROP, and uh, possibility of any other abnormality like hemorrhages. It has been well documented here, and just need to tick so that then nobody forgets about any particular part of the disease. And lastly, we have final documentation about whether the ROP was present or not, any other disease, and along with that, there are Indian recommendations which will be updated timely, and there's an associated QR code which will simply lead you and the patient's attendant. This is meant for the patient's attendant so that they can watch a video in Hindi, and that is the Indian language, and we can watch about the disease and they can have understanding about what ROP is in simple terms. And this, I hope, should motivate and help those who want to start ROP, and those who are not doing it will definitely think about starting it if they find my lecture useful. Thank you.